Welcome to Clarity Education Systems, your trusted guide to passing the PMHNP certification exam with confidence. I'm Dr. John Rossi, a certified psychiatric mental health nurse practitioner, and I'm here to help you master the critical concepts and strategies you need to succeed. This video is a special free excerpt from our exclusive weekly live sessions held every Wednesday night at 7 p.m. Mountain Standard Time. It's called Live with Dr. Rossi. These live sessions are designed for our Clarity students, offering practice questions, detailed rationales, and an open forum to tackle the real challenges you're facing throughout your studies. Today, we're diving into high-yield practice questions with evidence-based rationales, just like you'll see on the exam. So, go ahead and grab your notes, and let's sharpen those test-taking skills. First question we have up is, a 25-year-old female presents to the clinic reporting an unusual phenomenon where she feels a physical sensation on her own body when observing someone else being touched. For example, if she sees someone tap their shoulder, she feels a similar sensation on her own shoulder. She finds this experience fascinating, but occasionally overwhelming in crowded settings. What is the most likely diagnosis? Our answer selections include A, mirror touch synesthesia, B, tactile hallucinations, C, conversion disorder, or D, empathy-related tactile processing. Go ahead and take a second. You can pause here if you need to. Try this question out. Okay, so which option makes the most sense here? If you picked mirror touch synesthesia, you're correct. Now let's break it down a little bit. So mirror touch synesthesia, this is a fascinating and rare neurological condition. When individuals with this condition observe someone else being touched, their own somatosensory system, the part of the brain responsible for processing touch, is activated as if they were being touched themselves. So studies show that the mirror neuron system plays a significant role here. This system typically helps us empathize and understand others' actions. But mirror touch synesthesia, it's hyperactive, leading to a real physical sensation. So imagine how overwhelming this could be in a crowded place where people are constantly interacting physically. It's not harmful, but it can be overstimulating for some. Now let's talk about why the other options don't fit. So tactile hallucinations involve the sensation of touch without any external trigger. This is common in conditions like schizophrenia, substance intoxication, or withdrawal. But here, the sensation is directly linked to observing others, not random or spontaneous. So C, conversion disorder. Now, conversion disorder is also known as fictional neurological symptom disorder. It presents with neurological symptoms like paralysis or sensory loss without a medical cause. But the key difference is that conversion disorder is triggered by observing others. It's more about psychological conflict manifesting physically. Then there's option D. So this one sounds right. Empathy-related tactile processing. But this is referring to understanding and the emotionality relating to others' experiences. But it doesn't cause any actual physical sensation. Mirror touch synesthesia is more intense. It's not just an emotional empathy. It's physically felt. Okay, so key takeaways from mirror touch synesthesia. This is observing touch, activating physical sensation. Remember, understanding how sensory processing works is going to be essential for recognizing rare but real conditions like this mirror touch synesthesia. It also reminds us how incredible and complex the brain truly is. Okay, let's keep the momentum going. On to the next question. A 33-year-old female presents to the clinic reporting symptoms consistent with pregnancy, including nausea, abdominal enlargement, breast tenderness, and cessation of menstruation. She states she's been trying to conceive for over 2 years and recently experienced a miscarriage. Physical examination reveals signs of abdominal distension, but a pregnancy test and ultrasound confirm she is not pregnant. Based on this presentation, what is the most likely diagnosis? Our answer choices here are going to be A, delusional pregnancy, B, factitious disorder, C, conversion disorder, or D, pseudocyesis. So take a moment to think about it. What diagnosis best explains this patient's symptoms? Go ahead and pause the video if you need to, or the podcast, and give it a try. Okay, so if you chose D, pseudocyesis, you nailed it. Let's unpack this one. So pseudocyesis, or false pregnancy, this is a rare but complex condition where a person develops physical signs and symptoms of pregnancy without actually being pregnant. This includes symptoms like nausea, breast tenderness, abdominal enlargement, and even the cessation of menstruation. But here's what makes it so fascinating. The symptoms are not fabricated. They are real to the patient. This condition is often linked to intense psychological factors, such as strong desires to become pregnant, fear of pregnancy, or unresolved emotional trauma. In this case, the patient has a 2-year history of infertility and a recent miscarriage. Those emotional stressors can significantly contribute to pseudocyesis. Research suggests that hormonal imbalances, particularly involving prolactin and luteinizing hormone, may play a role along with psychological stressors. Now, let's break down why the other options don't quite fit here. So option A, delusional pregnancy. Now, this might seem similar, but delusional pregnancy involves a fixed false belief of being pregnant without any physical symptoms. It's usually seen in psychotic disorders like schizophrenia, and our patient is experiencing real physical symptoms, not just a belief. B, factitious disorder. Now, in factitious disorder, individuals intentionally produce or exaggerate symptoms to assume the sick role. It's a form of psychological gain, but in this scenario, the patient's symptoms are unintentional and not fabricated for attention. Option C, conversion disorder. This presents with neurological symptoms. Think paralysis, blindness, or seizures without any physical cause. Pregnancy-like symptoms don't fall under this category, so obviously it doesn't fit. So the key takeaway here, pseudocyesis is going to equate to physical pregnancy symptoms without actual pregnancy, and this is driven by psychological factors. So conditions like pseudocyesis remind us how deeply the mind and body are connected. Emotional distress can profoundly affect the physical health, and understanding this relationship is key for you as a PMHNP. All right, let's keep the momentum going again. On to the next question. All right, so in this case, an 80-year-old female patient living in an assisted living facility is brought to the clinic by staff due to concerning behavioral changes over the past few months. She has become increasingly irritable, forgetful, and displays notable personality changes, including impulsivity and hypersexual behavior, which are out of character. The staff also report that her sleep patterns have become erratic, alternating between insomnia and excessive sleep. Her medical history includes hypertension and type 2 diabetes, with no known history of psychiatric conditions. Physical examination reveals mild tremors and a slightly unsteady gait. What is the most likely diagnosis? So our options here are going to be A, Alzheimer's disease, B, frontotemporal dementia, C, delirium due to polypharmacy, or D, neurosyphilis. Take a moment to think this one through. What diagnosis best explains the combination of behavioral and neurological symptoms? Again, go ahead and pause the video or podcast if you need to. Take a second to check this one out. All right, so if you selected D, neurosyphilis, you're spot on. So let's explore why this is the best answer. So neurosyphilis, this is a late-stage manifestation of untreated syphilis, where the bacteria invades the central nervous system. It can occur decades after the initial infection, especially in older adults. So this patient's case raises red flags, right? Mood disturbances, personality changes, cognitive decline, hypersexuality, and neurological signs like tremors and gait instability. These symptoms align with general paresis and neuropsychiatric presentations of neurosyphilis. So if we take a closer look at Kaplan and Sadek's A Comprehensive Textbook of Psychiatry, it emphasizes that neurosyphilis can mimic other dementias, mood disorders, or even psychosis. So diagnostic testing with rapid plasma region, or the RPR, or fluorescent antibody absorption, FTA, ABS, it's going to be crucial for confirmation. So early detection is key because it's treatable with penicillin unlike degenerative dementias. So let's take a look at the other diagnoses and why they didn't make sense. So with Alzheimer's, this is typically presenting with gradual memory loss and cognitive decline. While mood changes can occur, things like hypersexuality and rapid personality shifts are uncommon. Alzheimer's also progresses slowly, unlike quicker behavioral changes seen here. Option B, frontotemporal dementia, or FTD. This often involves personality changes, disinhibition, and even hypersexuality. But it generally affects younger individuals, typically between 45 and 65. Our patient is 80, which makes this diagnosis less likely. Option C, delirium is an acute and fluctuating situation, often caused by medications or infections. It can cause confusion and mood changes, but doesn't explain the chronic progression or hypersexuality seen here. Plus, delirium doesn't usually present with tremors or gait instability unless the medications directly affect the motor system. All right, so key takeaway, neurosyphilis. This equates to mood changes, cognitive decline, personality shifts, and neurological signs as it pertains to untreated syphilis. So this case is going to highlight how important it is to consider reversible medical causes of psychiatric symptoms, especially in older adults. Neurosyphilis can look like many other conditions, but timely diagnoses and treatment can dramatically improve the results and the outcomes. All right, you're doing a great job. Let's dive into another critical area, developing communication strategies for patients with severe neurological conditions. This is something very important and every PMHNP should understand. All right, so a 50-year-old male patient with locked-in syndrome following a brainstem stroke is admitted to a rehabilitation facility. He is fully conscious with normal cognitive abilities, but experiences complex paralysis. The healthcare team is developing a communication strategy. Which of the following methods is most appropriate for this patient? So we have A, hand signals facilitated by physical therapy aids. B, speech-to-text technology using facial expressions. C, eye movement communication such as blinking or tracking devices. Or D, use of a voice synthesizer controlled by head movements. All right, take a moment to think this one through. What communication method would work best for someone who's completely paralyzed but fully conscious? All right, if you answered C, eye movement communication, absolutely right. So let's take a look at why. So locked-in syndrome, this is a rare neurological condition most commonly caused by a brainstem stroke. This leads to complete paralysis of nearly all voluntary muscles except for vertical eye movements and blinking. Cognitive function remains fully intact, so patients are aware of their surroundings but cannot speak or move. This condition is why we utilize that eye movement communication. It's going to be the most effective strategy. Tools like blinking code or advanced eye tracking devices allow patients to express their needs and thoughts. These technologies are not only empowering, but can drastically and dramatically improve a patient's quality of life. So studies have shown that eye tracking devices and custom communication boards are going to enhance communication for patients with locked-in syndrome. These methods align with their preserved eye movements, and this is going to make them both practical and compassionate solutions. All right, so why were the others wrong? A, hand signals. So unfortunately, this is going to be impossible. Patients with locked-in syndrome have full body paralysis. So hand signals simply aren't an option. B, speech-to-text technology using facial expression. So again, facial movements are typically impaired and locked in. So speech-to-text software, this is going to rely on facial expression, and it's not going to be effective here. The patient can't control their face or trigger their commands. And then voice synthesizers controlled by head movements. Again, great for patients with limited but functional motor control. In this case, though, they can't move their head. That way, this option is unusable. So this case is going to highlight how critical it is to understand a patient's preserved abilities and adapt care accordingly. For patients with locked-in syndrome, eye movement is their bridge to the world. It's our job to make sure that bridge is as strong and supportive as possible. All right, so moving on to our next situation here. All right, we have a 47-year-old male that presents to the clinic after a sudden episode of syncope while attending a comedy show. Witnesses report that he appeared pale and briefly unresponsive before recovering spontaneously. He denies chest pain, dizziness, or a history of similar episodes. Physical examination and an initial ECG are unremarkable. Based on the patient's presentation, which of the following is most likely the underlying mechanism of this condition? Is it A, increased sympathetic stimulation leading to atrial fibrillation? B, transient interruption of electrical heart conduction caused by increased thoracic pressure during laughter? C, vasovagal response due to emotional stimulation during laughter? Or D, coronary vasospasm triggered by intense emotional excitement? Think carefully about how intense this type of situation could cause a great impact on the cardiovascular system. Which makes the most sense? Go ahead and pause. Try it. All right, so the answer here is B, transient interruption of electrical heart conduction caused by increased thoracic pressure during laughter. Intense laughter can significantly increase intrathoracic pressure. This is similar to the Valsalva maneuver. This pressure change can temporarily disrupt the heart's electrical conduction. This is going to lead to a brief heart block. This phenomena, often called laughter-induced syncope, causes a sudden drop in cardiac output, resulting in fainting. Now, in most cases, this condition is self-limiting, and it doesn't indicate underlying structural heart disease. However, it's going to be essential to recognize it because patients may not realize that their laughter can cause this physical impact on their heart. All right, so option A, sympathetic overdrive can trigger arrhythmias like atrial fibrillation, but this condition causes palpitations and irregular heartbeats, not brief, isolated syncope related to laughter. C, that vasovagal response. This is common and usually results from emotional stress, pain, or standing for too long. It involves a sudden drop in blood pressure and heart rate. But this patient's syncope was linked to increased thoracic pressure, not a vagal reflex. And then D, coronary vasospasm. So coronary vasospasms, this causes transient chest pain due to sudden narrowing of coronary arteries. It can lead to arrhythmias, but this patient had no chest pain or signs of ischemia. So this case is a great reminder that even something as joyful as laughter can trigger unexpected physical reactions. Again, as providers, it's our job to help them recognize rare presentations. That way we can help guide safety for our patient. All right. At this point in our live sessions every Wednesday night, we typically transition into an open forum. So this is going to be your time to ask questions and get support you need. We are open for questions involving challenges you're facing in your semester, topics from the Clarity Review Program, concept from your personal study materials, practice questions you've completed, or anything else that's on your mind. This open forum is about supporting you and making you feel confident and prepared. So if you're a current Clarity Education System student, you can join us live through the PMHNP student portal. Just click the live session link on the main page of the student portal. Remember, y'all, you're not in this alone. We're here to help every step of the way. We want to make sure that you succeed in your certification. So before we wrap up here, I want to leave you with a few words of encouragement because this journey isn't easy, but it is worth it. So, David Goggins, this is a retired Navy SEAL and endurance athlete. He reminds us that our limits are often self-imposed. Feeling tired is natural, but stopping when you're tired means you might never reach your final or full potential. So remember, don't stop when you're tired. Stop when you're done. This journey to becoming a PMHNP will push you. It's demanding, exhausting, and overwhelming at times. But you didn't start this to stop halfway. You started it to finish it. So you have to push through fatigue. Every step brings you closer to that ultimate goal. Now on to my last thought. Muhammad Ali, one of the greatest athletes of all time, speaks to the sacrifice and discipline it takes to achieve greatness. He hated training, but he endured it because he knew the reward was worth it. So right now, studying might feel grueling, long hours, endless reading, practice exams. It's tough. But every minute you invest now is shaping the profession you and the professional you will be and that you will become. Remember, As he stated, I hated every minute of training. But don't quit. Suffer now and live the rest of your life as a champion. You're stronger than you think. Every challenge, every setback, it's preparing you for the incredible work you're meant to do. So don't stop when you're tired. Stop when you're done. This is Dr. Rossi, and I'm going to see you next Wednesday at 7 p.m. Mountain Standard Time if you're part of our review programs. If not, please enjoy this free excerpt here, and remember to stay focused, stay driven, and keep going. Bye-bye.